Okay, I think we've got the numbers we were anticipating. So, morning everyone, and welcome to today's event by TEC Cymru Communities of Practice on physical assessments in a virtual ward. I'm your chair for today, Kerry Phipps, and we've got a few slides just to start with in terms of housekeeping, and then move on to our speakers. So before we get started, ask you to follow a few simple rules to ensure the event runs smoothly. So if you can please mute your microphone and keep your camera off to help with connectivity. And in terms of questions and comments, would be great if you can pop those in the chat at the side. They will be monitored throughout the speakers, and we'll use those in terms of the questions and answers session at the end. We're mindful we might not get to all questions, so if you want to leave your name against them, just in case we don't get to them and we can follow up individually afterwards, or it might be then that we use that in terms of themes for future events as well, which we'll be revisiting at the end as well. Just to confirm, the session will be recorded and put online after the event as well. At one point in the event, we will pose a particular question, and we're going to use Mentimeter in terms of that. So there's a QR code there, as well as the website and the code in terms of taking part, and we'll show the results of this poll during the session. So if you want to get that sorted as quickly as possible, that would be great in anticipation. We'll also be, or if we just pop back, Catherine, because we'll be tweeting throughout the event as well. And if you're on Twitter, would be great if you could tweet and use the hashtag as well in terms of at TEC Cymru. Thank you. So just a very brief few words in terms of who I am and why I'm here before we go on to the most important part, which is the speakers. So I'm Kerry Phipps. I'm the National Allied Health Professionals Lead for Primary and Community Care, allied to the Strategic Programme for Primary Care. And a key focus of my role is how we optimise the allied health professions offering accessibility across primary and community care, not creating a siloed primary care pathway, but the predominant place in which we provide our skill set and support our population, using a proactive, preventative, whole system pathway approach to recovery and rehabilitation, which prioritise services at home or as close to home. Video consulting has entered our business as usual, and it's of no surprise that allied health professions, or AHPs, are one of the predominant professional users of virtual consultation. And I'm very pleased to be your chair for this morning's event, where you'll hear from clinicians who have adapted to using video consulting to conduct physical assessments and are offering interventions virtually with innovation and transformation of practice. So my very happy to introduce our first speaker, who's James Druce Perkins. James is a dietitian at Ymgynghori University Health Board, and his talk with regard to eating disorders in a virtual ward. James, over to you.
Hi, thank you everybody for having me. I know there are a few people who can't hear things a little bit, but I hope it gets sorted soon for you. I'm just about to share my screen, so hopefully everybody will be able to see my presentation. So, as I already said, my name is James, and I am one of the dietitians that's based in Ymgynghori, which is kind of Newport area, but Gwent-wide. It's a huge health board in South Wales, really. And it covers quite a lot of areas. So I'm not sure if people are familiar with Ymgynghori, but you've got Monmouth, Newport, all the way up to the valleys. It's quite a diverse population group, as I know everybody's is, really. But as I said, I work in eating disorders, and I think it's been a difficult time for everybody, particularly during COVID. And I think completing physical assessments in a virtual ward can be quite difficult. And I think in the initial stages, it was really, really hard to do. So I feel quite privileged. I think coronavirus, the COVID pandemic, absolutely terrible. But what I am amazed at is how people have been thinking on their feet, been very flexible, and people have just changed their practice. And I think in some ways for the better as well. So what I hope to cover in my presentation, and please somebody stop me if I talk. I can talk for Wales, so by all means just give me a nudge or a poke, a virtual poke, and stop me. But just in case you're not aware, I just want to provide a little bit of a background to sort of what eating disorders are, particularly focusing on anorexia nervosa and maybe bulimia nervosa today, just because they can hold quite a lot of risks. And I think managing that in a community setting alone is quite difficult, let alone in a virtual world, and what sort of the current evidence-based treatments are. I want to go through sort of the risks associated and also how I've kind of tried to manage these risks and how our team in Ymgynghori have managed. And I guess finally, I think it wouldn't be a complete slide without a benefit and drawback, kind of what have we experienced and what are we still learning from. So I hope to sort of share my own views with that as well. So I guess from a background then, there's about 1.6 million people sort of living with an eating disorder in the UK. And out of all of those, I think a small number, about 10% of those suffer or live with anorexia nervosa. And one of the reasons why anorexia kind of gets a big amount of press is because it does actually have the highest mortality rate of any mental health concern. And I guess the leading cause of death is normally a myocardial infarction or sort of a heart attack, basically. And the other sort of 90%, which actually sounds like a huge figure, is things like bulimia nervosa, binge eating disorder. And I want to say a reasonably new eating disorder, but ARFID, which actually has been around for a number of years, but only really recently in the last couple of years has been sort of looked at, researched, which is avoidant restrictive food intake disorder. So normally those young children who are always described as fussy or faddy or selective, which, okay, you can have a fussy child, they can be fussy, but ARFID is a very prominent diagnosable eating disorder, which kind of is characterized by a young person not growing adequately, having a nutritional deficiency, not managing to eat very much, whether that's due to sensory concerns, a fear of sort of choking or swallowing difficulties and things. And usually these young people have been tube fed or relied heavily on oral nutritional supplements as young children. So they've potentially missed weaning or really important developmental stages. So that's a very, I want to say a newish diagnosis, but it's been around for years. And then OSFED, which is kind of other specified feeding or eating difficulty, which if they don't necessarily fit neatly into a nice diagnostic criteria, they might end up fitting into an OSFED criteria, which means they could have a bit of lots of different things. We've all heard, I guess most people might have heard in the media that mental health difficulties, the incidents have increased. I think the national average for eating disorder referrals, that people have noted an increase of about 50% in England. However, in our health board in Ymgynghori, we've seen over a 100% rise in referrals. So our team's still the same, but I guess we're seeing double the amount of people coming through, which is, it's quite concerning, really. And I guess what the benefits of that is people are being recognised and people are being seen. So I'm not the type of person that will shy away from work. It's kind of, actually, I'm glad that the amounts of referrals are going up, because if people are recognising it, people are saying, actually, this is really risky, this is concerning, then it means we get to see those people, whereas they probably have always been around and we've just not seen them. I think COVID has also acted as a bit of a catalyst for young people, which is really unfortunate as well. So I think actually people have become iller quicker as well as a result. And I guess the risks that we're seeing and the risks that we're sort of managing in community, you've got the physical risks, which particularly in anorexia are the physical consequences of starvation. There's not many studies about the physical complications, particularly because it's very unethical to starve people. The only study really that we can relate to is the Minnesota experimental, the KEYS study. And that was basically on men and conscientious objectors to the war, so they entered a starvation study. But that doesn't need to be repeated because we're seeing it now and people are being recognised as having effects of starvation. So things like low blood pressure or poor circulation, or we do notice a lot of bradycardia or slowing of the heart rate, loss of periods in females, and lanugo hair, which is kind of fine downy hair that grows almost to protect the body and keep their body sort of warmer, I guess, because a lot of them do feel cold, and particularly the extremities are cold. And derangement in blood biochemistry is quite common, particularly if somebody has gone through a period of starvation for a long time. What can happen is they can, if they start eating and drinking, particularly carbohydrates is the nutrient that causes it, but they can induce something called refeeding syndrome, which is electrolyte disturbances upon the commencement of nutrition. So usually potassium, magnesium, phosphate, those start becoming a bit low because they're involved with carbohydrate metabolism in the body. Interestingly enough, most of these physical consequences you can't necessarily do without seeing a person. So I think that's where particularly virtual consultations and being able to see people has been really, really helpful. I think with the exception of being able to do a blood pressure or blood biochemistry things or doing an ECG, a lot of the sort of physical health consequences where you can see somebody looking like they've got a low BMI or they've got a very pale skin or hair loss, you can see that virtually, so you don't necessarily need to be face to face. And I think asking the questions, are you dizzy? Are you faint? Are you passing out? Are you blacking out? Those are the questions that normally people are very honest with because they're quite scary symptoms. So I think that's where the benefit of being virtual, actually, you don't need to see them, but as long as you're asking the right questions, I think that's okay. It's good enough sometimes. You also have the things that you can't see as well, but the psychological consequences such as depression or anxiety, or even the dampening down of emotions, I think that's quite a common symptom because what's the point in your body thinking about emotions if you're going through a period of starvation? You can get obsessive and very rigid thinking, and concentration can be very, very poor. That hasn't been picked up during COVID because, of course, schools haven't necessarily been in, and I guess you can opt in or out of virtual lessons in school, or you can't really tell if somebody's paying attention. So a lot of that hasn't been picked up. But additionally, young people can get sort of that self-hate and disgust. And I guess the biggest consequence for a lot of people would be the social consequences. But I think this has been something that has been really difficult to navigate during a pandemic, because how do you manage not being able to eat out? How do you manage avoiding social events when there are no social events? They're not happening. So normally the thing that motivates young people during treatment is, what about your friends? What about going out? What about university? How are you going to manage? And let's help you manage. It's kind of, we've had a lot of, well, it's not happening anyway, so what's the point? So that's been a bit difficult, but that isn't necessarily physical. So my next slide is basically about how I kind of manage the risks as a dietitian. So it's very specific to sort of my role. But we do follow something called Marzipan Junior Guidelines. So these, you can actually, I say Google, other brands of search tools are available, but you can Google the summary document for Marzipan Junior, and basically it gives you a table of all the physical risks and also the psychological risks, and it allows you to score somebody as high, low, medium, as colour-coded risk assessment. A lot of that, though, couldn't be completed because you can't do ECGs virtually and things, but you kind of get an idea of how risky somebody is. What we've done is I've asked a lot of families, which kind of goes against all of eating disorder treatments altogether, but I have asked families to purchase weighing scales, particularly during the time of not being able to provide face-to-face appointment, just to get an idea. And if that isn't plausible, we have other methods, but we've also had really creative ways of measuring height as well, by using a door frame like with a book and lining it and seeing if somebody's growing. We've had people getting out tape measures and things. Not incredibly accurate, but I think during such a difficult time, sometimes a guide is better than nothing at all. The benefit of doing virtual, though, is the fact that you can see the young person, you can see the family. It almost feels like a home visit. You're allowed in somebody's home. As you can see, I've got my background free, but you can have a glimpse into my environment, which sometimes is really, really helpful. And we couldn't have done that before because of capacity and demand and things. We can see inside people's cupboards and things. So I could say, oh, what's in your fridge? What's in your cupboard? Which is nosy, but if you know me, you know I'm nosy and I'm a bit pushy, so I'm like, what's in there? Show me. But the fact that you can see the young person, you can see if they're pale, you can see if their hair is thinning, you can see, and as a dietitian, you can kind of estimate somebody's weight just based on visual appearance. So you can get an estimate of risk, which is great. From a detailed dietetic assessment, that could always be done virtually. And what I think it's done is allowed us to share that a little bit easier. As you can tell, I've shared my screen today, which is brilliant. So as somebody is giving me a diet history, I can actually show them the nutrients in their diet as that's being done. So using nutritional analysis software, which is all done electronically anyway, I could share my screen and show them on a color-coded chart. I could show them the selenium, the calcium, the magnesium and things. And that actually, if it's done correctly, could save a lot of money because you don't need to do blood tests to check if somebody's got a nutritional deficiency necessarily. If there's a very clear deficiency, if they are not having any calcium, you know that they probably should have calcium in their diet. And that can save a lot of tests and doesn't need to be done face-to-face. So the other thing I wanted to touch on, which I think it's quite creative actually, but MUAC and ulnar length. So you can measure somebody's height using ulnar length, but you can also measure somebody's BMI using MUAC. In adolescents, MUAC or BMI isn't great, but what it can do is give you an idea of somebody's mid to upper arm circumference, which is around the middle. So if somebody is a very, very low body weight, actually you can just do a MUAC and you can measure that again in centimeters a couple of weeks later, a couple of weeks later, a couple of weeks later. That can be done with a tape measure. And an iron bevan, there are areas of social deprivation, so we have actually just used pieces of string, and people have measured the pieces of string with a ruler. But to me, it didn't matter how we did it, as long as we kind of knew, was somebody restoring weight adequately or were they not? And as I mentioned in the very first slide, the evidence-based treatment for eating disorders is very much a family-based approach. So what we have done to manage risks in community is upskill families to complete blood pressure, to complete weights and heights accurately, to complete MUACs even, and share those findings with us using email, or we've used mobile phones and things just to say, like, please, this is their weight, just to keep you updated, which we've had to think very creatively about and make sure that was able to be done safely. So contracting had been done using phones, by the way. So measuring physical risk and monitoring it has actually been done quite successfully. This is just an example because MUAC actually can be done anywhere, but this is an example of how to do a MUAC, and that's just to kind of measure and keep an eye on things. It's normally done in areas where food is just not available, so it's a good way of measuring malnutrition, particularly in young children. So really briefly then, before I finish, benefits, actually there's tons. I quite like virtual, and I'm really glad to have been a part of Attend Anywhere and doing groups and things on that initially, because I felt like I was able to jump straight into it. Thank you, Alka, for allowing me to do that with you. But I find it very convenient and flexible, as do the families. They are actually at the moment requesting that we do a bit of both. So they're saying, can we do virtual that week? Can we come and see you this week? And actually getting the balance right is brilliant. And I'm really privileged to be able to do that and offer that service. We can also get other members of the MDT in. So adult services, transitions wise, to manage the risk of transitioning somebody to adult services. It's kind of, yeah, join the appointment. I'm in Caerphilly. oh, well, I'm in Monmouth. Well, we can still join the appointment. It's absolutely fine. So lots of different people can get involved. The biggest thing is people actually restored weight and recovered during COVID because families were at home, families were all together, and they took ownership of the difficulties that that young person experienced. So when they were providing weights, when they were doing the MUACs, when they were sort of measuring whether things were working or not, they were able to say, right, this isn't working, we need to change things as a family. And they just went with it, and it was brilliant. And I think the biggest thing is that virtual home visit that I mentioned, which is great because you can see the environment, but also the ability to view risk. And I think that is a testament to video calling. That's a testament to health boards being able to just think on their feet and change practice quite quickly. There are some drawbacks. I think there's drawbacks of everything though, isn't there? But I think if you needed bloods, if you needed an accurate blood pressure, if you needed to really see somebody, I think sometimes that has to be done on a face-to-face basis. I think virtual can go so far, but also face-to-face can go so far. Social economic inequalities, and I remember it's so diverse, and some people can't, but they don't have Wi-Fi or they don't have access to smartphones. So that had been a little bit difficult, but we did overcome that and provide services over the telephone. But the biggest thing I experienced was young people can opt out very quickly, particularly if you have an eating disorder, you potentially don't want to change anything. That's the nature of the illness. So opting out is very easy because you can switch your camera off very quickly. You can walk away very quickly and you can't be followed. And the one thing dietitians, we always get painted with a bad bad brush, really. We are the bad cops going in sometimes, particularly for an eating disorder. An eating disorder does not want to see us. The young person wants to see us, they want help, but the eating disorder doesn't. And sometimes distress can just manifest itself. And that can be difficult to manage virtually because, as I said, they can walk away distressed and you can't necessarily try and comfort them. So that has been experienced, but we've learned our lessons from that. We've kind of thought, actually, we can manage it differently next time and say, I can see that you're distressed, because that's the nature of a video call, you can see it, and maybe ask them a little bit about it and stop that distress happening. But I think overall it has been a reasonable success going virtual, and it means that you can manage the risks. I think that's the difference. If you'd spoken to me 2-3 years ago, I would have said, virtual, no. But I think being thrust into it, it means that actually we've had to do it, and it's demonstrated how successful it is. Thank you very much, everybody. I hope you've enjoyed.
Thank you, James. That was really interesting, and I know we've popped in the side. If you've got any particular questions for the speakers, don't forget to put comments there. Perhaps a couple of things that, if I just pick up that sort of really resonated with me. Mm-hmm. The wider family engagement, and I know I've heard this with other areas as well, that sort of really bringing that ownership and engagement as a whole family is, and the impact of that across a wide range. So really, really interesting there. That flexibility in terms of approach that it provides as part of the toolkit that suits, families and individuals' needs as well as, sort of the way that we deliver. The opportunity with wider multi-professional communication, much more collaborative working around the person, as opposed to us all working in parallel in doing our thing in silo. So that's really, really positive. And that opportunity regarding risk identification that the medium brings. The one flag which is really really important, you've highlighted in terms of social economic inequalities and inverse care law, and these are really important considerations for us as we transform our practice. So it's a vital part of our toolkit, but we don't want it to be at the expense of exclusion for some of our hard to reach. So really brilliant. Thank you so much, and I'm sure I'll be coming back with questions afterwards to you. Thank you.
Brilliant. Thank you. Bye now. I'll turn my camera off.
So next, we've got two speakers now together. We've got Leah Watson, who's speech and language therapist at Swansea Bay University Health Board, with Dr. Shirley Jonathan, consultant community paediatrician at Swansea too, in terms of early years autism toolkit and pathway. Over to you.
Thank you. I'll just bring the slides up. Have my slides come up? Kerry, sorry, I can't see whether they've actually...
You've just got a big picture of me at the moment.
Oh, so if I
There we go.
just... Okay, there we go. Thank you. Okay. Find the right slide. Here we go. Okay. Okay, is that good now? Yep, I'll just share from this slide. There we go. Okay, thank you. Yeah, thank you for having us to talk about our project. It'll just be me today. My name's Leah. I'm presenting, but I co-led this project with Dr. Shirley Jonathan, and she is on the call today. But I'm going to be speaking as we're talking about the telehealth aspect, and that was largely my role within the project. So we're from Swansea Bay Health Board, and our project is about early years autism toolkit that we developed over COVID, and this got recognised as a Bevan Exemplar Fast Track project, and we led this project from September 2020 to March 2021, so this year. So the things that we'll discuss today are linked to that time frame. And before I go any further, I just wanted to highlight that this was a team effort. Even though it's only us on the call today, we couldn't have done this without our team. And we just wanted to thank everybody for embracing and adapting their practices during this time. So as with everybody, when the pandemic hit, it caused quite a lot of disruption to our pathways, and we had to stop clinics for 5 months while staff were employed and we weren't able to bring people into clinic. Our assessment that we usually use for autism in the early years is usually clinic-based pre-COVID, so a joint assessment in clinic, and then sometimes an ADOS if they needed another assessment, which is a gold standard assessment for autism. Because this isn't standardized with a mask, with the social partner wearing a mask, when we did start up our clinics or start up our sessions again, we weren't able to use this standardized assessment that we're used to using because it's not standardized with a mask. So it really did kind of wash away our pathway. So we had to research into what else we could do, and how else could we see these children. So we looked into telehealth, and we were really pleased to find that there's a growing evidence base for assessing autism, which is pro telehealth, and there's a big systematic review by Sunderland et al. In 2018, which looks at lots of different evidence bases, and we were really found that very, very promising. So we built a new ship to navigate our way through the ever-changing waters of the pandemic and developed a toolkit for assessing autism in the early years for children who are referred under 5, and developed a new pathway. And this was important to us because we wanted to keep the flow of assessments going. The lists are usually quite long anyway, and we wanted to make sure that families could have access to early intervention as soon as possible. And sometimes a diagnosis opens doors for this because parents can better understand their child, schools can understand what provision the child needs. And so early diagnosis and early intervention is really important, and we see that as part of our role to provide that. So we had many aims with our project, but one of the most important ones was that we wanted to personalise the child and family's diagnostic journey. It's not one shoe fits all. All families and children have different needs, and so we wanted our pathway and our toolkit to reflect that and have different tools for what was needed. We also wanted to reduce the amount of assessments and make our pathway more prudent. So our outcomes overall from September to March was that we were able to diagnose 85 children, or reach an outcome of 85 children, and 75 of those we gave a diagnosis of autism. So I'm going to talk a bit about the actual toolkit now. So the first part of the toolkit is the telehealth parental interview. That's carried out by the consultant or the paediatrician, and it's gathering a case history with the parents, finding out what their child is like in everyday situations, what their concerns are, what the child's needs are. And this was carried out sometimes by telephone and sometimes by video call. The second part of the telehealth assessment was the specialist speech and language social communication assessment. And from early on, we could recognise the benefits of this approach. I'm quite excited to implement it because it gave us a window into their natural home setting, with them interacting with their caregiver, their parent, the person that they have the most attachment to, which has so many benefits in itself compared to interacting in a clinic setting, usually with a therapist and a stranger that the child doesn't know. So already, it gives us a great opportunity to see what they're like in their own surroundings, where they're more relaxed, they've got their own toys. And just as James was saying, he'd like to have a look in their cupboard to see what food they had in there. I suppose with us, it was looking in the child's toy box, being able to see what toys they had and what type of things they play with and what type of toys that they like, which is really important for an assessment of autism in terms of assessing their play and what they're interested in. So it was more functional, more meaningful than a clinic setting. And, some children with emerging autism can find the clinic really stressful, just even coming in and waiting in the waiting room. They could be really stressed and off baseline and dysregulated even before they enter the clinic room. So for those children, especially those very young children, the home setting, doing video call, that already, gave them a better opportunity to show their strengths as well as their needs, which is important, for the family. And parents were highly active in the assessment, and hopefully felt empowered that they were the people delivering the assessment with our coaching, and delivering that observation. It also reduced travel, so it was greener, and it reduced the footfall to hospitals, which was forced upon us really, and it's less time then on infection control procedures. So we could see the benefits from the start. So some of the tools that we use, so with the under fives, there's a real mixture of children. Sometimes we have pre-verbal children, some using some single words only, and then some with actual language and sentences. So for the pre-verbal children, some of the examples of things that we would try in a speech and language observation are if the child wasn't able to interact directly over the screen, which a lot of them weren't able to, that's fine. We would do an observation of the parent-child interaction, so seeing, are they giving, are they showing things to their parent, are they engaging in shared enjoyment with the play. We would observe their play skills, so what are they doing with the toys that they have at home? Are they playing repetitively? Are they playing symbolically? So that gives us lots of rich information. We would also coach the parents to elicit some communication. So that would be things like seeing if they would request more of something. So asking the parent to blow bubbles or give them a bit of a snack, and then waiting to see what the child would do to ask for more. So eliciting, requesting, and also things like seeing if the child could follow a point, coaching the parent through calling the name, pointing at something and seeing if the child would follow. So there's lots of little probes that we can try over video call that we don't need to do, that can be done without being face to face. And we can also interact with the child directly if they are able to do that, using lots of light up props and very sensory, visually pleasing props like puppets and things over the screen to assess their social communication. If the children were older and had a bit more language, then we would collect a language sample. So that could be through book sharing with their parent or through small world play. If they were able to interact directly with the screen, I would try and elicit some conversation, and this could be to do with their interests. So the example on the screen is a Minecraft background on Teams. So if the child is interested in Minecraft, I could elicit some conversation around Minecraft or Lego or whatever it was that they were interested in. We also use topic cards. So we would choose a topic and then have a conversation with whatever the card said. If the card said favourite films, then I'd elicit some conversation around that. And also sometimes I'd use pictures to probe emotional literacy, inferencing, and their social thinking. So what might this person say next? What might happen next, with some picture scenes as well. We also used video sharing. So this supported us to understand the impact of the children's needs in everyday situations. So we would use this not all the time, but just when we had an assessment where we thought there were gaps. So if we felt that we needed to see a child in a different situation, for example, playing with a sibling in an everyday situation like brushing their teeth, or at snack time, or at a time that the parents felt that they would like to show us a time that they thought their child was experiencing some difficulties or something, a particular situation that was really difficult. So we used a secure portal for this, the NHS secure portal, and I would send some instructions out with the types of things to do, remind them not to show any bath time clips or any getting dressed clips, things like that for safety reasons. But we found this was really helpful with some children who we just needed that bit more information, and we weren't doing any face-to-face at that time. And we found that, especially with a few examples, that this did really help us then come to an outcome when we could see these valuable clips. And there was one child in particular who was appealing his additional learning needs was statement, and because we were able to come to an outcome of what his needs were and offer him the diagnosis, this really helped then with him having the provision that he needed in that time frame, which if we had waited for face-to-face, it would have been too late, because there's only a certain time frame for the appeal. So it's things like that sometimes it is really important to get a diagnosis. We can't rush a diagnosis, but sometimes we want to make it as smooth as possible for parents. So the video clip sharing is based on research by Smith et al., who developed an app called the Nodder app, which is for assessing autism. We didn't use this app, but we used our own video sharing portal. But the evidence came from Smith, and he found that there was no false positives with his video clip sharing app. So that was really promising. So after the parent interview by the paediatrician and the speech and language therapist telehealth assessment, we would then have a consensus discussion, again via video call in a group, in an MDT, to decide, did we have enough information? Did we have enough evidence that this child met the criteria for autism, or did we need to bring them in face-to-face? And some children did need to be brought in face-to-face. So we need to kind of acknowledge that not all children can be brought to the end of the pathway just by telehealth. And when we needed to bring somebody in face-to-face, we also used a new assessment called the BOSA, which stands for the Brief Observation of the Symptoms of Autism. And it's worth mentioning that this assessment can also be done virtually. We chose not to do it virtually because of the practicalities of we'd have to deliver the specific tool, the toolkit and the resources to each family and then pick them up afterwards. And we felt this just wasn't practical within our work, within our capacity. But you are able to do this face-to-face. We had loads of success with this, and if anybody's interested in talking more about this element, then feel free to email us afterwards. But today we'll focus on the telehealth aspect. So this diagram here just summarises the amount of children that we were able to give feedback only just by telehealth alone. So 42% we were able to give feedback, a feedback session to give them their diagnosis or their outcome, and no face-to-face was needed, which we felt was a real success. And the clinical markers that we'd like to look at going forward is that we do expect that some children will still need a face-to-face, and this is congruent with other findings in the research. Duraz et al. He found that he couldn't rule in in 30% of cases, you couldn't rule in or out ASD, and that ours was higher than that. But we have to remember that this research was done with all ages, and our children are much younger because we're the under fives pathway. So we need to, going forward, we are going to offer a mixture of approaches, and we found that it's the children with sentence level language and a mixed presentation that often need that face-to-face assessment. But we would have found that usually on our pathway pre-COVID, that they were probably the children that would have needed an ADOS or would have needed an extra assessment anyway. So the parent experience of the telehealth sessions, we did a digital questionnaire for parents, and we had some people complete that. It was a small sample, but it's a good start. So 93% of parents strongly agreed that they were satisfied with the video call from the speech and language therapist. All of them except one said that they would recommend the session to those with similar needs. They found the advice that they received, because we would always give advice as well after the assessment, they found that that was helpful. And 2 people were more ambiguous, but most people felt they strongly agreed that the advice was helpful. 93% of parents strongly agreed that their child's needs were understood, and that's really important to us, that they were understanding their child's needs, even if it's done by video call or face-to-face or whatever method. Our main aim is to understand their child's needs and the family's needs. And a quote here from the parent, you can get a good idea of her behaviour when she's in her own environment and acts more naturally, is a common theme that we had from the video call sessions. When we asked parents, when the pandemic is over, where do you think it's best to see your child? Overwhelmingly, people did choose a clinic appointment. So there's some work here to be done about putting that, so parents have trust in the video calls as well. But interestingly, the group that had the telehealth said that 60% said that they would be open to a mixture of both, or that they would prefer a mixture of both. So when they were given the chance to try telehealth, it was actually, they were more pro telehealth, if that makes sense. But the group that had the BOSA, which is the face-to-face, said 75% said that they would prefer a clinic appointment, and 20% a mixture of both. So we do have to look at those, listen to what parents are wanting as well, and just remembering that this is a small sample too. So I just wanted to share some of the limitations of telehealth that I feel for assessment of autism in the early years. So I found that there was increased preparation time to help the parents plan for the assessments. So I made some parent crib sheets, and sometimes I would need to phone parents depends on their child's needs, to go through what we would do in the session, what toys they would need available, so that they understood exactly, what types of things we would try to make them feel at ease. Because it's important to remember that some of these parents have needs themselves. They might have difficulties themselves, and so they need more coaching maybe than other parents. So it depends, on different families. Some families were really comfortable with it and felt very natural, and then so it just depends on the family. But it's just sometimes you just need to allow extra time to support the families with that. There's often some limitations with the technology. So for example, if I was sharing pictures, this only really worked if they were using a tablet or a laptop. It was more tricky on a phone if they couldn't see the details of the pictures. So that was for the older children with language, that they would prefer then a tablet or a laptop so that would be more accurate. Sometimes it was helpful to have an extra parent there to be the cameraman, because sometimes if the child is moving around and you want to see their whole body language, you want to see their eye contact, then you need somebody who's moving the phone or whatever device they're using around as well, to see what the child is actually doing with the toys and things. So sometimes the view was a bit restricted. And video call fatigue, I think parents are now choosing face-to-face at the moment, just because I think they're a bit fatigued with video call. But in talking about all the limitations, there are so many benefits to video call as well, and I think going forward the ideal pathway would be a mixture of both, as James has also said as well. And it would be good to develop the idea of using the video clip sharing as well, because that was really helpful in some situations where the family could send their clips of their child in everyday environment, so we could see the impact. So it would be good to develop a digital tool for this purpose, a more user-friendly one where clips could be shared back and forth, where we could use that for therapy as well, demonstrating techniques and approaches too. We also want to continue to empower parents to be the social partner. That was another huge benefit of video call, and that can be replicated in clinic to a certain extent, but I think more so when it's their own home, to carry on making the parents more active in these assessments. We want to continue to reassure the parents of the efficacy of telehealth, that they trust the process. So there's some work, to be done there. We wanted to move that forward. And we are also trying to improve the quality of intervention pre and post diagnosis. So now when children are identified as having social communication needs early on, we are carrying out a parent group session by video call where we're showing them little clips of things they can try, talking through some of their concerns and offering advice through that forum. And we've had a mixture of intake for that, but it's something we're piloting, so that's positive. And I think that'll be easier now that it's done over video call as well for some parents due to childcare issues and things. So we're going to continue to put the families at the heart of what we do, and we still haven't, decided on what our pathway looks like now. Now that we're coming out the other side and we're starting to do more joint clinic assessments again, we need to look at our pathway again and reshape it now to decide what's best, and using a mixture of telehealth and a mixture of clinic sessions. So I do have a mentor question. I just wanted to know, out of interest, would there be any appetite for developing a digital tool across Wales for allowing patients to share video clips and you to share them with them? So my question is, if a user-friendly digital tool is available that allowed a secure video clip sharing between patients and clinicians, would you use this?
Just while you're doing that was brilliant, Leah, and see if the responses are coming up.
Oh, great.
Perhaps if I reflect back a few points, because there's a couple of questions I've noted down for later, Leah, and I can see that David has posted one in the side as well. If everyone has got comments or questions, if you want to post as well, that would be great. I think while we're still doing that, a couple of things from me. It was really important, the flag you made in terms of the growing evidence base, and I just wanted to highlight that in terms of contributing to that evidence base, because of the practice that you're leading on across Wales, and Leah would count you in this, that the importance of us contributing to that and recognising our part in that and how we shape the way forward because of all the great work that everyone's doing. Again, there was the flag in terms of the improved assessment opportunity, because you got to understand the children's behaviour in their normal environment. And I could see there was a comment in the side saying nosy practice is good practice, if we relate it back to to James' presentation. But then again, it was that flag in terms of family engagement and that empowerment and that ownership as well as part of that. So that was really great. The flag with regards to green health, brilliant. Developing trust. But the other one for me that I don't think is always appreciated is that increased preparation time. There's perhaps an inference, well, we're not doing the travel time anymore, so we can do more in terms of activity, but actually it can take quite a bit of time in terms of prep from your point of view and who you're working with to get ready, in readiness to get the best outcomes from virtual consultations. So I thought that was a real flag. And then in terms of the increasing opportunity that a lot of services are using in terms of that proactive pre-intervention model. And this particularly flags for me, you know, my focus, I said to start with, was how we have much more direct, timely access to our skill set, as opposed to people having to go on waiting lists and deteriorate in order to meet a threshold of criteria to access us. So that developing model, in terms of that pre-intervention, a proactive, I think is really important. So I think there's a couple still coming across, but we've got a really interesting split there. Do you want to make any comments, Leah?
Yeah, excuse me. I'm just going to move out of the sun because the sun is blazing, which is it's lovely to have the sun, but I can't see the screen very well. Sorry. Yeah, I think it's really promising to see how many people would be. Nobody has said no. So and 11 definitely, 26 say yes. So I think there is an appetite out there for developing a digital tool that allows that video clip sharing. We do have one in the NHS, but it's not as user friendly as maybe it could be, and it's very difficult to share video clips via emails and things because of the length of them that we sometimes need. So I think maybe as a team across Wales looking at developing an app, or I'm not very technical, but something I don't know, a cloud or some kind of digital tool, I think would help a lot of therapies and clinicians out there. So I just wanted to plug that on this forum.
Thank you, Leah. That's really helpful, and obviously it's an event by TEC Cymru, and just a flag as well, I'm very mindful when we talk about a secure network, it's got to be wider than NHS for health and social care. And a lot of our certainly allied health profession services are hosted by local authorities. So how we have that much more multi-professional, collaborative, but secure is definitely a question. So really, really great. Oh, we've got one no. Oh,
one no. Okay.
One no, but overwhelmingly positive. So really, really helpful. Thank you. Right, and if we move on to our final presentation today, Dermot Ferguson, who's the chair of the National Back Pain Pathway and Clinical Network in Northumbria. Now, we had a recent event, or TEC Cymru supported a recent event where is it? You know what? Apologies if I'm pronouncing your name incorrectly.
No, you're pronouncing it fine. That's all right, Kerry. No problem. 2 minutes, grand.
But I know we've brought you back over, if you like, because there was a real call out from, in particular, Welsh physiotherapists who were really interested to share their practice and learn more from yours. So great opportunity to have you back today, and over to you.
I'll just try and share my screen here. Now I'm on 2 screens, so I can't see if you could see my screen. Can you see that? Or can you see anything? You can see that screen, can you?
Yeah, we've got. Yeah.
Now the difficulty I've got is you can see that screen, but I can't see any of my notes. Okay, great. Okay, so can you see the screen? Okay, is that everything okay?
Yeah. Yes, we can see.
Brilliant. Okay, so as Kerry was saying, my name's Dermot Ferguson. I'm clinical specialist physio. And nice to be back in Wales. I spent 5 years as a student in Cardiff, but even though it's virtually, so I haven't been back in a few years. I'll be back again, please God. So just to outline today, I'm just going to give our experience from the Northeast, based up in Northumbria, just below the Scottish borders. I'll give you a bit of a background and our setup with delivery, and then a little bit of help with the virtual consults. We have been early implemented of the Attend Anywhere program, and that meant that we were quite quick to get going when COVID hit. We were also sort of a little bit of serendipity. The chap who had the videos and the headsets was walking past my office one day in the middle of COVID, and I said, "Can I have a few of them?" And he said yes. So that meant when there was a shortage, then we were able to get them quickly. So just to give you a bit of background of where we actually are. So based up in Northumberland, North Tyneside. So in this sort of region here, I'm actually based here, but we cover all the way up to Berwick, which is about an hour and a half's drive away. As far as topography, it's probably a little bit flatter than Wales, but as expansive with lots and lots of villages, market towns, different environments. very industrial, lower down around the Tyne, and then more rural country out. So quite similar, I think, to parts of Wales. Now, the talk I'll give is basically to oversee some of what tips and pearls we've got. But before I go into that, I'm just going to give a few stats as to what we've learned and how we've got on. These were based on the scaling up virtual consults across the NHS. This is a really good tool, actually, if people are new to virtual consults. You'll find that most research around virtual consultations is based on Trish Greenhouse's work in Oxford. She's done lots and lots of work on this, and it all refers back to her. This is a headline from the BBC website locally, and essentially one of the big drives for our trust was to save patients time and money in travel and car parking charges, because we are such a big area. As I said, we have 4 district hospitals across our trust, but people were spending from, I think one area, the average OPT travel time was 26 miles, and other areas it was like 5 or 10. But there is a quite variable outset of it. So what it meant was during the pandemic, at the peak of it, we obviously all went virtual. But during that, over that year, we saved 2.38 million miles in travel, and it is something to be aware of. That's not just carbon footprint stuff. That's actually time, valuable patient time, that to come and see me from different parts of our region is essentially a day off work for somebody. It's not just nip down to your GP. So has that been maintained? And I think that was one of the concerns, was this going to be maintained, or would we lose the benefits of virtual? So the recent stats have shown that we've maintained that. So from a previous average miles travels of 16.9, we've maintained at 11.5. So in the 6 months up to now, we've saved a million miles less travelled this year. We had some concerns, and I think you can see from the slides there that was the peak of the pandemic. We came down, and then we got into our process here. Forgive me, I'm looking at our other slide here, but we're maintaining at the 30%, and that is our target for our trust region, is to offer 30% virtual consults, which we appear to be maintaining. And I want you to note how we offer it. We still offer face-to-face. We still offer telephone, and it's an offer to the patient to what suits them best. So what do we do now? I have to say, I laugh at myself now. I'm now talking about virtual consults, and I have been the chap for years saying we can't do physio virtually. This will never work. It's all about hands. It's all about the touch and feel. How can you really do this? And now I'm a convert saying actually it has its role, and I think it is really, really beneficial in an awful lot of people. And we should reflect that 80 to 90% of a diagnosis is based on the patient's history and their story. The objective test examination are typically to confirm or to focus your clinical suspicions. So it is really, really valuable to get that earlier rather than waiting to see a patient face to face in 4 or 6 weeks time. I don't know what your waiting list times are at the moment, but at least you can see somebody earlier virtually. So now I'm sure you're the same. We use Attend Anywhere here. Before the appointment, we send personalized Attend Anywhere info to everybody, confirming the video, telephone appointment, what happens if things go wrong, what the other contacts are. It's really worth spending a bit of time on this, of getting it right, getting it sorted out. Now, the structure here that I'm going to go through is based on Lisa Roberts' work. It's a really good paper. I would recommend everybody to read it who does any virtual consults. It's quite valuable in just going through the process. As I said, the one from Barts and Health Foundation again is really good. So what I do, I'm just going to go through these and see what it says. So my greeting and intro, I say, hello, my name's James Ferguson. I'm a physiotherapist phoning from North Tyneside. Remember, look at the camera, not your own image. I tend to minimize my image down to nothing because we all like looking at ourselves. We all get drawn to our own images. Then a bit of courtesy. I generally say thank you for inviting me into your home. Are you able to take a call now? The issue with this is that if they're in the car and they're treating this like booking a hairdressing appointment, it's not really. This is a consultation, so we typically say if you're unable to if you're in the car, can you pull over? We'll obviously not be able to do the physical virtual exam today, but we'll start with the subjective and then we'll have to rebook for the physical exam. As far as the equipment check, you want to make sure everything, can you hear me okay? Can you see me all right? We tend to use the chat. On the Attend Anywhere is pretty good. If you can't hear stuff, well, I'll put a chat in there. So I can't hear you at the moment. I'm going to try and reconnect, make a few. And there is a few times that I've sat on the phone looking at somebody on the video, and it works okay. You just need a backup on that. The remote experience is probably less difficult now. I generally say to people, this is a bit strange, and these are in these interesting times to do this over the video, just to calm things down, to essentially say this is new to us as well. We're still getting used to them, and I think that generally puts patients at ease. It's to acknowledge that sort of strangeness, and it helps with the therapeutic alliance. Signpost them to say you will be taking notes. If you look down, it's not because you're not interested, it's because you're taking a record. I tend not to type, I just tend to take notes as I'm going along, mainly because I can't type. So after we've spoken, I'll say we will be examining you. Are you okay for me to check your movements? So you want to be in a room that they can actually move around and you can actually see them. And then, is there anybody else here to help? Now, that is the preamble that I go through, and it's only really at that's pretty generic, and it's only after that I've said hello and everything else that I go in and do the ID check. So say, okay, let's get started. Could I check your address? Can you confirm your date of birth? All these things have all been done already because obviously they have clicked on an Attend Anywhere link, so they know what's going on, but you still need to confirm these things. You need to confirm the reason for the call, the agenda. Your GP has referred you to see me as a specialist, discuss what's going on. Then I will ask you to move, and I'll ask you to show stuff. Then after that, there's the important thing of the sort of key clinical question. Typically face-to-face, I'll just say to somebody, tell me your story, what brings you to see me today. I know with other people would say, what would you like us to focus on today? If it's a bit more sporadic, you could say the GP has referred you in with leg or back pain or whatever, but I tend not to use that because it's not about the patient. That's about the diagnosis, and actually you want to find out what the patient's issues are, not what the diagnosis is. So after you've done that intro of tell me your story, then shut up. Just don't say anything, and use your timer if you want for 1.5 minutes. You can nod, you can say yes, yes. Don't fill that emptiness with your insight. Let them speak. The 92 seconds is the average time for a patient to be able to explain their issues, concerns, and expectations of the consultation. So try not to interrupt. We can bring them along if needs be. Once they've done that, then you can follow that up with the sort of TED questions of tell me, explain to me, describe to me. and go into the sort of more detail. After that, to explore, their issues, concerns, expectations. I'm unsure what the NHS Wales saying. We have sort of asked for questions, and what's important to me. What do you want to get out of today? Those type of questions. Remember as well, the whole point of these consultations is to understand what's going on and to offer our help as required. When it's not going through a checklist. So that whole thing of active listening is not just waiting to speak. It's actually listening and reflecting back and trying to understand, listening to understand, not to tell people what's going on. At that stage, then we go into the red flags, special questions, and they can be, you're going to have special questions for each area. At that stage, you'll have some idea what's going on. As far as this assessment of the back and neck, I'm going to do a quick slide on this just to say a setup, and then I'll direct you to where you can go into detail on that. I'll do that in the next slide, but I'll come back here on the. When you're given information, remember it's consent to inform. You want some information on this, not just tell them you need to do this, this, and this. You'll recap and you'll wrap up, and then you'll close. Okay, I'm going to move on to the next slide because I'm just conscious of the time. So, what pearls have we picked up over the time? The setup is really important. They need to be in a room big enough to be 6 foot away from the camera. I generally ask them to place a camera either on the sofa or on a dining room chair. That tends to sort of do right. And then they come about 6 foot away, and that will give you a full view of the person. Then from there, you're going to talk about, pain location, what's going on. Could you please point to the area and describe that to me? What are you experiencing? What's going on? You'll ask them to move and to do a sort of standard objective measure. You're going to go through each of those things steadily, but remember, you're not there to guide them, so you're going to have to be quite direct with your vocal guidance. Could you slide your hand down to the right side of your thigh? Could you slide it down to the left side? Could you bend forward, gently bend back? Just go through it, and then you can see it straight back. Always make sure they can hear you as well before you stick them to walk 6 foot away. And then from there, you see the movement, and you're trying to assess what they're like neurologically. And I think this is always difficult, that, I can't do a full neuro exam. But remember, for any intervention, such as sort of progressive weakness, such as any major stuff, if they're not able to walk straight, they can't heel and toe walk, there's a weakness there. You can see that. If they can't sit to stand or do squats, there's a weakness in their quads. So it is a case of use some ingenuity to sort of work stuff through, and then you can go from there. I do get patients to test reflexes, and they're pretty good at it, so they can do it. But again, it takes a bit of practice from that. Now, just final slide there of, we've been doing this, as I said, for over a year and a half now. It has offered lots and lots of benefits to managing patients. There's definitely people that we need to bring in, and there's people that want to come in. We've noticed that in the our older age group, they may not have seen anybody for a year and a half. So now when we're doing our outpatient appointments, we offer, would you like a virtual consultation, video, phone, or would you like to come in? And for people who are au fait with it, they love coming in. For others, they'll say no, I've had enough. Now I've put all these links on here, so you can follow that up. I would recommend Lisa Roberts and the telemedicine one that goes through a full assessment on there. We're currently working with UK SSB, UK spinal boards, to have a script and have a performer that we're happy with, that people can use virtually so that they're covered. So on that, I'd just like to sort of finish up, and thanks again, and happy to take questions for afterwards.
That's great, Dermot. Thank you so much. Really helpful, practical session as well. And those links, I know that the slides and presentation will be available afterwards. Those links really vital. And I know from a TEC Cymru perspective, for those of you who haven't visited the website, there's links with all of the sort of the key recommended, and Simon's very helpfully popped it on the side as well. So some real opportunity for people to go away and have a look at that. A really key reflection from me with regards to your talk was that golden minute, and don't fill it with your insight. Try not to interrupt. And so often we're just waiting for our turn to speak as opposed to really listening and understanding what's being said. So I think that was a really, really helpful flag for all of us in terms of that golden minute, if there's something to take away today. Thank you. Right, so I think we're moving to questions and answers, and we've had a few posted in the side, so many thanks for that. And if there's, we've got a bit of time, and if there's any others, I'll perhaps go to one of the first ones, and maybe I'll pop this to James, but it's sort of for everyone in the panel, in terms of how, when we're developing service models, we ensure that equitable offer across areas of social deprivation and digital poverty. Or, you know, I live in West Wales for areas of poor connectivity. So perhaps pop that across to James to start with, but perhaps if anyone else wants to come in as well.
Yeah, I think that always takes me back to when I completed my rotation in primary care, because I think the sole aim for me was always to bring care closer to home for people. I think instead of having this central hub which people have to travel to, I think making use of available spaces actually closer to home is really, really important. I think social deprivation, we can ask for as much money and as much funding as we can, but we all know that that takes time. And when you're working with an individual that needs to be seen immediately, I think see them where they can be seen. And I think particularly with the pandemic, as long as it's socially distant and safe to do so, I think that's what our service is doing at the moment. We're bringing the care to them, but offering virtual, offering face-to-face to everybody at the moment, just so that everybody has an option, basically. I hope that's answered your question, but I think the biggest thing for me is bringing it closer to home. I think for whatever reason, whether it's social deprivation, whether it's transport issues, whether it's just personal preference, I think it's just really, really listening to what they need.
Thank you, James. And I can see there was a couple of comments in the side with regards to picking up on that as well. And I guess it's just to reflect back to everyone that the Attend Anywhere programme in Scotland was actually called Near to Me, recognising that not everyone would be able to attend anywhere. And so there was a different way of thinking. So really helpful. Perhaps Leah, there's a question that I thought me helpful to bring up you when you said it was a team effort, but I know I'd be interested in all of the panel, I'm sure we all would, in terms of you had some flags in terms of family, in terms of that video call fatigue and new ways of working. And I wondered how that had translated in terms of the team and staff, you know, perhaps some of the feedback initially was that we'll do this in the meantime. This isn't necessarily how business will continue. Our business will continue, but that's not the case. A lot of us are spending more time online. And I guess sort of if there were any challenges in terms of that transforming the way that we work that you'd come across in terms of the team.
Yeah, I think everybody's kind of workloads and how much they're on video call is different. So I can't answer for all of the team, but I think trying to we have to accept that it is more part of our working day now is to be more virtual. And so I think we have responsibility with ourselves to build in those moments of getting up and having a movement break, or making sure that we have a bit of time away from the screen, and building those practices into our daily working day, and maybe having some support from the trusts and from our senior management teams to acknowledge that we probably, if a clinician is on a video, in and out of video calls all day, that needs to be built in for well-being as well. Yeah, but I think in our team we do have quite a good mixture of face-to-face and video calls, so it hasn't, maybe we're not as fatigued as maybe you could be with that. So I don't know whether anybody else wants to add anything, whether that's answered the question.
Thank you, Lee. That's really helpful. Does anyone else want to come in? Dermot or?
Yeah, I think our experience has been we've sort of reformulated people's timetables to have 30% virtually. So as our trust goal is that 30% will be virtual and then the rest face to face. We're obviously, and I'm sure you're in the same process of trying to catch up with waiting lists and everything else. And I think we're probably going to keep it at that level there. And some people are choosing to do that 30%, so they'll do a whole day at home, and then another half day or shorter sessions virtually on site. So it's given that flexibility as well. I would reflect on that. I found it quite difficult. We're being invited into other people's homes, but I'm also inviting patients into my home, which I've always been very strict on. That's, this is my space, and I think I found that really hard. I probably still do. So I do kind of lock the door. I actually go to my son's bedroom because I'm never in there, and he's got a desk, and so that's a different space. So I think there's something about that, trying to step work away from your normal home life.
I agree with you. It's the strategies that we use, and I don't know if we can pop it in the side, but there's a link, hopefully we can pop it in the side in terms of that virtual working and the impacts, and sort of perhaps the way that we can support that in a helpful way going forward at the moment that TEC Cymru are looking into. So I think that's a really helpful flag, one that I struggle with at times in terms of that management as well. So definitely, and I can see some posts in the side from Wendy as well. So important. Thank you, Drew. I think this consultation at the moment will really help and shape our way forward. Just in terms of that 30%, was that sort of anything behind the 30%, or was that sort of seen as reasonable? Or
do you know what, our chief exec, we had so many complaints about car parking that this across the trust, and I'm sure this is just the same across Britain and Northern Ireland. The main complaints are about not patient care. It's about how come I've got to pay for parking, or how come I've got to wait to get in there, and they weren't on time and everything else. So a decision was made a few years ago, pre-pandemic, to say, no, we need to work more virtually. We need to do this. And the 30%, I think, was seen as a good start. I think they'll keep it at that level. I can't foresee it changing at the moment. But I think it was a nice goal, and it seems to match up. The evidence from Oxford is that virtual consults are much more effective on follow-up appointments. However, that was done in a sort of secondary care environment. It didn't have sort of community primary care stuff. So we've got to take some judgment on where was that information gleaned from. As well as that, that was at a time where video consults were different. People weren't as au fait with it. So yeah, I think 30% is not bad.
That's really helpful as well. And just to flag with everyone, because we are slightly different, our ambition is the primary care model, where predominantly our activity is in primary and community care, and the English model is around that sort of additional layer of primary care specialism, if you like, from an AHP lens. So just to flag that with everyone, thank you. There was a question in terms of the secure portal and saving video clips as part of an individual's record. Now, I'm aware that there are memory capacity considerations if we start to do that. I guess this is a question for all of our panel in terms of discussions around videos and keeping that as part of the record, and if there's anything you can share in terms of those conversations. Dermot, if I come to you first, you're still on screen, and then we'll go to James and Leah as well.
Do you know what? I know it sits, the videos can sit in system 1. I'm not sure what systems they use in Wales, but I know on system 1 and EMIS web, which are the main primary care, and that you can post videos on there and they stay securely on that site. I know locally in our trust, I don't think we have access to any video stuff at the moment. So, yeah, a hands up saying I don't know.
Thank you, Dermot. It's vision and EMIS predominantly over here, but it's that whole health and social care across, and that interconnectivity across platforms, isn't it? James, I've got you on screen. I'll let you come in.
Oh, that's okay. I think there are a lot of unknowns when it comes to that, isn't there? Because it's such a new kind of topic to sort of broach. I know we're still using paper records, which we are really kind of striving to do electronic records, which hopefully is coming in to practice at the end of the month. I think a good conversation with information governance and a good conversation with the creators of WCCIS, which is what we're hoping to use, would be really helpful. Because if videos could be stored as part of an assessment document, I think that would be brilliant, because we would have access to it, we'd be able to see it, and we would be able to sort of share that with obviously nominated health professionals that have access to it. And I think it can be quite insightful for health professionals to have access to that. But I think it's quite exciting, hopefully, if we can work towards it anyway.
Thank you, James. And Leah, I'm aware this is probably a conversation you've had in terms of the Mentimeter question and that sharing of video clips. Can I bring you in?
Yeah, so we didn't save any of our clips on our shared drive. They just, with the Move It portal that we were using, after a certain amount of time, they're not saved because of storage capacity. In the past, when we've saved video clips, for therapy, we've had lots of conversations with clinical governance where we have to make sure that the parents of the children assign a consent to say they're happy for it to be shared, and we state exactly what we will use it for, and then give them the option of if they change their mind, that they can always get back, they can always ring in and say, please now delete the clip. So we have to give them that information as well if they want that, if they wish for that to happen. But with our project, the project we spoke about today, we didn't save any clips to the shared drive. They're just in the portal. They're only there for a certain amount of time, and then they disappear. So, yeah.
Thank you, Leah. And I can see Sianed, and Sianed, that's a really great question in the side in terms of consultations being recorded, and I think it's one perhaps to take back with TEC Cymru Programme Board and revisit, because we have had that conversation previously in terms of how we keep a record of consultations from a clinician and a patient or an individual's perspective. So really helpful. I'm mindful of time, and there was another really helpful question posted earlier that I'd like to bring in either Gemma or Alka in terms of this. It was with regards to the data capture as part of that evaluation framework, how you can audit the miles travelled and saved in terms of green health. Alka, I've got you on screen. Do you want to come in?
Yeah, thanks, Kerry, and thanks to Dermot, James and Leah for a fantastic presentation. We've been capturing the carbon savings and mileage. There are carbon footprint calculators that are available. But for those who are doing it on a small scale, you can even do it on Excel and use Google Maps and things like that. So if people are interested, link in with the research team. I'm happy to pop my email in the chat. But going through the consultations we've done, it's roughly 250,000 as of this week. And we've saved about 7 million travel times, Dermot. So, it's just encouraging, not in terms of just the mileage, but the savings in terms of what we are doing for the planet, but even the work we've done with benefit and challenges, that's been one of the consistent things from patients and clinicians as to the frustration about parking and the savings on travel. I know it takes time, Lee, you were saying in terms of preparation, but it's probably moving forward and thinking how we can use our time best so that we can work better with our patients. So be it saving on parking, but preparing for these virtual consultations. But please get in touch. We've got the research team. They'll be more than happy to work with you if you want to capture something for your own service.
Thank you, Alka. I think it's really important that in terms of evaluation, you look at that whole rounded in terms of activity, in terms of staff wellbeing, in terms of patient experience and outcomes or individuals' experience and outcomes, but that wider impact in terms of carbon footprint as well, really helpful. There's a comment in the side that's come up. Important to remember that teams working virtually from home need support, and we need to make time to encourage team building and peer support. Now that, and again, whether we can repop it in the side so it brings it to attention. There's a consultation with TEC Cymru at the moment with regards to that, but perhaps to our panel members reflecting on that, have you undertaken activities to try and facilitate that team building and peer support that you could share across? Dermot, I've got you front and centre on screen. I'll come to you first.
Yeah, as I said, we've reconfigured our timetables now, so 30% are virtual. So that, and we are still doing we're allowed to go face-to-face team briefs now again. Quite big gym, so we're lucky as far as that goes. So I think in a way we've set up the timetable so that we can meet face-to-face. That we're actually still encouraging that, and that we're trying to limit the amount of physical and social isolation that staff are having, and we're having during the height of the pandemic. And we're sort of conscious of that, so that they have time that they're in and not constantly out. Yeah, I think that it's different for everybody, because I think it's whether you work in that hub and spoke, or whether you're based in a practice. I think it's different. But it's really important.
So a more structured approach, I guess, is in those strategies. James and Leah, can I bring you in? Perhaps things that your experience?
Of course. So I think things have progressed quite quickly in the last 18 months for our service. Our service didn't stop functioning as an eating disorder service. So we immediately, on say the Friday, said we have to be virtual. On Monday, everything changed to virtual, and we carried on sort of work as normal, but not normal. What we did in those early stages, though, we really recognised the importance of supervision, but team supervision. So that was initially done on a monthly basis, where we would set aside about 1.5 hours on a day that most people could make a reflective sort of session, a supervision session, really. What we've done moving forward is we've asked the teams, what do they want to do? So do they want to do a mix of virtual, working from home, coming into the office? And we're still doing practice supervision, and we're offering that out actually for face-to-face, but also for people who want to work from home on those days as well. So that's something that we've kept in the diary, we've kept rolling with, which we didn't have before. But I think it was good to sort of get people together and discuss the challenges that they're facing at the moment.
Thank you, James. And Leah, do you want anything to add? Anything from your?
Sorry, I was muted. Sorry. Sorry, I'll just add quickly that, similar to what the others have said, that we are, very much face-to-face and virtual, and a good mixture. But the one thing that I think is really important is that balance between when you are working from home, getting that work-life balance, because I think it's very easy for people when they're working from home to continue working past their work hours with all the pressures and capacity issues that we're all facing. And so I think that's a wider issue to just make sure that we're keeping ourselves well and maintaining that balance. I know it's something that I've struggled with and people in my team have struggled with.
Thank you, Leah. I'm mindful of time, and it's perhaps time to wrap up. I'm going to draw attention to a couple of links in the side bar. The one is in terms of that clinical reasoning and support in terms of clinicians. So there's the Digital Health and Care Wales link from TEC Cymru in terms of clinician support. And I can see, because Nikki, you'd posted a question there in terms of that. So I direct you to that support. There's a wealth of support there. And then the other link with regards to virtual working and in terms of that sort of supporting the way forward, if you like, just to flag there. I think the biggest thing is in terms of today's event, that transferability we've heard some fantastic presentations, so thank you so much, James, Leah and Dermot as well, in terms of sharing your developing work. It's been absolutely brilliant. I'm sure everyone would agree with that, and thank you to all of the audience as well in terms of your attention and engagement. In terms of going forward, there's a flag from TEC Cymru in terms of future events, and if there's something specific to focus on, and I know that there's a couple of points from today to really pick up on in terms of that recording and sharing information that will definitely feature going forward as well. So many thanks everyone, diolch yn fawr, and stay safe, and I hope everyone's day is good to you. All right, take care. Bye.